My name is Simon Herkenrath from Germany, and I'm happy to present this case of a Chiari Malformation type 1 and sleep-disordered breathing. This is a case of a 44-year-old woman with a body mass index of 55.7 who came to our sleep lab in August 2019. In 2016, this patient was diagnosed with Chiari Malformation type 1, a disease characterized by the herniation of the cerebellar tonsils through the foramen magnum into the upper spinal canal. Due to the resulting headache and paresthesia, our patient underwent surgical decompression in 2017. Known comorbidities comprised arterial hypertension, which was adequately treated with an AT1 antagonist, and obstructive sleep apnea, which was diagnosed in 2015 and led to the initiation of continuous positive airway pressure therapy. Due to the insufficient therapy success, CPAP was switched to bilevel therapy in 2017, which the patient discontinued 1.5 years ago due to pressure intolerance and perceived patient ventilator asynchrony. The sleep medical anamnesis revealed excessive daytime sleepiness, regular bedtimes with approximately 8 hours of subjective sleep length, and occasional difficulties falling and staying asleep. There was no evidence for manifest insomnia, hypersomnia, parasomnia, or sleep-related movement disorders. A physical examination showed no retrognathia and Mallampati class 3 with small tonsils. In extremely obese patients presenting to the sleep lab, we usually expect a narrowed upper airway due to the excess fat accumulation surrounding the upper airway, contributing to a high probability of obstructive sleep apnea. In most cases, we also find impaired breathing mechanics with reduced lung volumes as a result of abundant abdominal adipose tissue, posing a risk for hypoventilation. Beside impaired breathing mechanics, increased leptin levels are found in obese people. Leptin was found to be a positive regulator of ventilation. Elevated leptin levels serve as a compensatory mechanism for increased metabolism in obesity to maintain normocapnia. In hypercapnic obese people, leptin levels are further increased, while ventilation, however, is insufficiently adapted. This is believed to be due to leptin resistance in hypercapnic obesity. Also concerning ventilatory control, obesity hypoventilation is associated with an impaired CO2 chemosensitivity, which entails a reduced hypercapnic ventilatory response. There is disagreement about whether impairment of hypercapnic ventilatory response in obesity hypoventilation is a contributing factor for hyperventilation or merely an expression of less favorable breathing mechanics or other underlying mechanisms. Coming back to our patient, the body plethysmographic assessment of lung function and the measurement of diffusion capacity showed normal or even high normal results and thus no signs of impaired breathing mechanics. A diagnostic polysomnography revealed a severe, predominantly central sleep apnea with an apnea-hypopnea index of more than 100 per hour. Mean oxygen saturation was slightly decreased, but 31 minutes of time spent with a saturation below 90% was relevant. In this 5-minute view taken from the diagnostic polysomnography, we can see a rapid succession of short central apneas alternating with short bursts of hyperventilation. In this section, the cycle duration of apnea and hyperventilation is remarkably short and regular. However, we also found periods of additional upper airway obstructions, as can be seen here. These obstructions led to longer respiratory events, aggravated oxygen desaturations, and emergence of an irregular breathing pattern. Central sleep apnea is usually based on a tendency towards chronic hyperventilation, as seen in renal failure, heart failure, as well as when staying in high altitude. Concomitant hypoventilation may occur, for example, with the use of opioids. The resulting breathing pattern is described by the term atactic breathing. As our patient did not take opioids or other respiration modulating medication, the central breathing disturbance we found is highly unusual, as in extreme obesity, obstructive sleep apnea and hypoventilation would have been much more likely to occur. Looking at the blood gases under different circumstances, we found still normal but untypically low CO2 levels at rest and at exercise, while during sleep they were even below the lower limit of normal. The transcutaneous capnometry, which was performed in parallel with the diagnostic polysomnography, also revealed a trend towards hypercapnia during sleep. Sleep-related hypoventilation with resulting hypercapnia, on the other hand, is definitely not evident throughout the recording. Last but not least, we found a clearly elevated hypercapnic ventilatory response indicative for an above normal CO2 chemosensitivity. This indicates the key pathophysiological aspect for the breathing pattern seen in our patient and is in stark contrast to what would normally be expected in extreme obesity. But what is the connection between CO2 chemosensitivity and central sleep apnea? An extent of ventilation adequately adapted to CO2 production is defined as normal ventilation and characterized by a stable breathing pattern. In case of an increased ventilation relative to CO2 production, CO2 levels decrease and lead to a cessation of breathing when falling below the apnea threshold. As CO2 production continues and CO2 level rises again, ventilation is resumed. In case of a breathing disturbance that causes a CO2 increase, normal CO2 chemosensitivity leads to an adequate ventilatory response with a short and well-dosed increase of ventilation and subsequent normal ventilation. In contrast, elevated CO2 chemosensitivity entails an inadequately high ventilatory response, destabilizing breathing pattern and promoting the occurrence of central apneas. To summarize our findings, our patient showed severe, predominantly central sleep apnea, exhibiting alternations of short central apneas and hyperventilation bursts. Periodically, upper airway obstructions occurred, further destabilizing the breathing pattern. Blood gases and capnometry indicated a trend towards hyperventilation, and the hypercapnic ventilatory response was clearly elevated. In this context, it is important to note that no other possible causes for central sleep apnea were found, although explicitly investigated. Overall, these findings are in contrast to what would be expected given the patient's high BMI. Thus, it is not surprising that CPAP and bilevel therapy, the latter increasing ventilation even further, were unsuccessful in stabilizing the breathing pattern and achieving normal ventilation. Thus, considering the parallels of increased CO2 chemosensitivity as seen in heart failure, we decided to establish adaptive servoventilation therapy. The corresponding polysomnography under ASV treatment shows an immediately stabilized breathing pattern, which could be achieved thanks to the adaptive pressure support modulation. Comparing the PSG results under therapy with the initial diagnostic findings, the therapy success becomes evident. This was also accompanied by a good subjective therapy adaptation, resulting in good treatment compliance after 6 weeks of ASV and a good symptomatic benefit with a marked reduction of daytime sleepiness. Let me conclude as follows. The available literature describes a high prevalence of sleep-related breathing disorders of 60 to 70% in Chiari Malformation type 1 with predominantly central respiratory disturbances, although obstructive and mixed events occur as well. Mechanisms discussed as potential causes of upper airway collapse in Chiari Malformation comprise the compression and traction of the 9th and 10th cranial nerves and consecutively on the pontomedullary nuclei. This potentially causes functional impairment of pharyngeal and laryngeal muscles, leading to upper airway collapse. An altered CO2 chemosensitivity may occur due to a compression of the medulla oblongata, affecting the respiratory center. Chiari malformation also jeopardizes the normal function of the glossopharyngeal nerve, which possibly result in an impaired signal transmission from the carotid body, thus further altering CO2 chemosensitivity. Despite extreme obesity and as we found no other apparent risk factors for central sleep apnea, our patient presented with an atypical central sleep apnea and mild hyperventilation as opposed to predominant obstructions and hypoventilation. This strongly suggests Chiari malformation type 1 to be the causative factor underlying the central sleep apnea. In the end, adaptive servoventilation with its ability to counteract the pattern of alternating apnea and hyperventilation was highly effective in our patient. With these words, I would like to conclude this enlightening case and thank you for your attention.